good evening and welcome to this month's Rural Doctors Broadcast. I'm Jerry Gannon. Thanks for being with us. Well, once again, the winter sports season is upon us, and so tonight our program focuses on sports injuries. Dr. Olga Ward will talk to sports physician Dr. Ken Maguire about some of the most common injuries across a range of popular sports. And we'll also hear sections of Dr. Gerard Taylor's presentation on management of acute sports injuries at last weekend's Rural Health West annual conference. And along the way, we'll get some boundary reports, tips and advice on the management of some of those injuries from former West Coast Eagle turned sports physiotherapist John Annear. We begin by asking Dr. Ken Maguire about the knee injuries that can be all too common for footballers, especially early in the season.
Ken, welcome to the program.
Thank you.
Ken, we often hear about footballers going off for a knee reconstruction very urgently, and they say, oh, the patient's done their cruciate ligament and it has to be operated on tomorrow. Why are they so susceptible, and why do they have to be operated on tomorrow?
Well, they're susceptible because they play sports that involve, landing sort of heavily at times or running at a fast pace and changing direction. So then, the comments we have is that they stop, they prop, and they hear a pop, and the cruciate ligament pops. A cruciate injury, of course, is actually a dislocation of the knee. The whole knee is deranged, so there are a lot of other secondary injuries. But the reality is they don't need to be operated on quickly at all. In fact, some of the best surgical results occur if you wait a couple of weeks till all the acute inflammation is settled. So they don't need to be rushed off to hospital. They don't need to be flown across the world. They just have to be treated with perhaps a joint aspiration, ice, using a splint such as a Richards full knee splint, and let the physiotherapist just settle all the acute inflammation.
Okay, now what is a Richards Fawnley splint when it's at home?
Well, you'll see patients have things in hospital where it looks like a cricket pad. It just wraps around the leg, has a little gap at the front, Velcro straps to pull it together.
All right, and a little hole for the patella. So you're not talking about one of those things that's got a hinge in the middle?
Nothing like that. Very simple post-operative knee splint. And they just put that on for a few weeks so they can walk around. They don't need crutches, they don't need anything else. They can sleep comfortably with the brace on, because otherwise when you're lying in bed and you twist and turn, the toe catches in the sheets and it feels sore, because you always feel as though the knee is coming out again. And they just treat it conservatively for a couple of weeks, make your time to see the orthopaedic surgeon. But in fact, you can live the rest of your life with a ruptured cruciate. You don't need an operation, it's not essential. But if you want to play at the top level, you probably do. So take your time, let it settle down, and then manage it in the cool, calm environment, no rush.
Yeah. So country patients who are keen on playing football but who obviously aren't playing at West Coast Eagles standard, however poor that might have been last year, they can be rehabilitated and they may not necessarily require a cruciate to go back to just football at district level?
Exactly. And so some of those patients might want to come down to Perth, though, because they may have still an MRI to be done, just to be sure that there's not associated damage to the medial ligament, lateral ligament, menisci, because there are lots of associated damage when the injury occurs. But if all of that's relatively clear, it's just a pure cruciate, they can often return to good level without an operation.
Right. Now, you were talking about stop, prop and pop, so this sounds like just a change in direction with none of these enormous pile-ups involved.
Yep.
I'd always understood cruciate ligaments to be part of this contact sport thing.
And most cruciate injuries are non-contact injuries, no contact at all. There's this famous story about the Subiaco Oval where they have the Bermuda Triangle, an area of the park where all the cruciates occur, where the guys run into that pocket, twist, turn and pop the ligaments. And it's been looked at now that grass, the surface is important, and the guys bulk up at the beginning of the season, so they're sort of a bit top heavy, and they've got all this power. And then the injuries often occur either the power time early in the game, when they're really forceful and racing in for turning, or at the end of the game when they're fatigued. They stop, prop, and they're just a bit lazy with the muscle coordination, and it pops then. So occasionally it can be with a tackle, but it's almost always without a tackle.
Yeah. Is there anything preventive that they could do?
No.
No? So they can't kind of work on the muscles or anything around the knee to make it more stable?
There's a lot of work that's being done by the human movement people at the moment to work on proprioception. So the physios will take people through and make sure they do all the wobble board, their hopping drills, their side hopping drills, just to prepare the knee. but unfortunately that doesn't always prevent them. But it's worth doing anyway, just for general injury prevention for ankles and other things. So that's still a good exercise to do. Yeah.
Now, with this 3-step rule in netball, you seem to see more women coming down with meniscal injuries rather than cruciate ligament injuries, and yet it seems to me that the mechanism of injury must be very similar.
It's almost identical. It's just probably the magnitude of the rotation through the knee is just enough to catch the meniscus and tear the meniscus, but not quite enough to fully dislocate the knee and create the cruciate rupture. But in saying that, the #1 sport in Australia for cruciate injuries is still netball, ahead of football, so it's a real problem. And then there's this push in netball now to turn all the courts into plexipave or rubberised because it looks good. But in reality, you get much less injuries if you play on grass. But it doesn't look as attractive, it's hard to maintain, etc. You get a slightly increased risk of ankles, but major knee injuries are infinitely smaller when netballers play on grass. But all the grass is disappearing. You know, rain, water, maintenance, etc. And so these grippy surfaces and grippy shoes have a big problem with regards to increasing netball injuries.
Now, in most country towns, you can probably get a plain X-ray of a knee, and you can possibly get an ultrasound, and you can often get not much else. Do you have any good clinical tips for actually making a diagnosis in that very acute phase?
Well, if you aspirate the knee, and everybody can aspirate a knee with a bit of confidence, and if there's a hemarthrosis, then you have a 90% chance that it's a cruciate injury. So that's the gold standard. Blood in the joint equals cruciate until proven otherwise. And then just clinical examination to see if they've got an anterior drawer sign or a Lockman test. These little tests to just test how the tibia moves backwards and forwards on the femur.
Yeah.
Now, once
I've only ever seen those in very chronic injuries and not in the acute ones because I think they must guard it too heavily.
So you've got to relax the patient and just talk to them, play with their knee as you move it around, and then just get a little bit of a feel. But again, if there's blood in the joint, you aspirate, treat with your ice compression, all those things, and your bracing, and re-examine them after 10 days or 2 weeks, and then you can feel it. You say, yes, that movement's there. So again, it may be impossible at the time of the acute injury to diagnose, but it's not an urgent problem. Take your time, give it a few weeks, and then re-examine.
Same with your meniscus, I guess, a few weeks.
Yeah, and people
work
say,
out what's
look,
happening.
should we take the meniscus out acutely? Well, there are 4 indications for taking your meniscus out. It's recurrent pain, giving way, locking, or recurrent effusions. If you don't have that, you can live and play sport with a torn meniscus.
Yeah.
So not every meniscus should be taken out. In fact, you could argue the point that perhaps you'd be better if you didn't take it out because it still has a role to play.
Yeah. Now, when you're doing some imaging, is a plain X-ray of any use whatsoever?
No, hardly any use at all. But occasionally you can see a fracture. So because it's a dislocation of the knee, you can actually have a lateral tibial plateau fracture. So it is useful in that sense. It'll also give you some idea if there's fatty globules in there that may again indicate an intra-articular fracture. You'll pick that up on the soft tissue views, but essentially it doesn't help you at all.
Now, our patients in the country often live with these types of injuries for ages because they're concerned about the rehab time. Suppose they did decide to go ahead and have a meniscectomy or a cruciate reconstruction. What sort of rehab time are they actually looking at?
Cruciate reconstruction is a year to play again. Meniscal operation, 6 to 8 weeks to play again. Now, there's a big debate. Do you do lots of physio or not? And some of the orthopaedic surgeons in Australia give their patients 0 physiotherapy after a cruciate. They say, just walk, get comfortable, do your own little exercise. They give them a sheet of drills because it's going to take 12 months anyway, so there's almost no point turning up to the physios for 12 months to rehab it. You just go through it yourself. So they don't have to spend a lot of time doing excessive physiotherapy. But the elite athletes would like to just accelerate the rehab a bit quicker, which you can do with a good physio program. But the average athlete, honestly, doesn't need much in the way of rehab.
Not even in terms of muscle strengthening for stabilisation?
No, they can do it all themselves, just with a little bit of a weight around the ankle or just standard quadriceps exercises and little hamstring exercise. Almost all can be done by themselves, or even a little skipping rope to get the proprioception. So it's a little bit of a myth that they must spend hours and hours and hours in the rehab. And that myth is propagated by the Americans, who believe that every athlete should have endless amounts of rehab. But there's no evidence basis to say that it's better by doing that.
So they see the physio, get a program, maybe see the physio again to make sure they're doing it properly, and then pop in every now and then to monitor it.
In the hospital, the physios might see the patient just before they go home and say, this is what you need to do initially, see you in a couple of weeks, how your quad's going, how your hamstring's straining, go home, do that for 4 weeks, see you 4 weeks later. Because it's a year rehab, so don't keep turning up.
It's a long time.
The quick test, or the information that will direct you onto the right track straight away, is just question the person how they left the playing field or court. If they've really been carried off, straight away that you know that there's been a significant event. Secondly, question when did they notice the inflammation develop. If it's within the first 2 or 3 hours, you know that something inside the knee's bleeding. So the structures that you're thinking of straight away are your anterior cruciate, or even the deep fibres of your medial ligament, or the medial retinaculum of the patella. So this is where a patella has possibly dislocated. So they're the main structures that you'd be thinking straight away if someone's left their playing arena, been carried off, they're in a lot of discomfort, the knee's blown up straight away. They're the structures that have to be properly addressed. The second one would be more that night or the next day, and straight away you'd be thinking more of the meniscus, the shock absorbers of the knee. And you'll often see that where the person's unable to fully extend the knee, they'll describe a sharp pain in their joint line, the inflammation's developed overnight, and that really, neatly fits in those sort of two categories of the most common things that we see.
So if there's a large effusion, which is often what presents to you, then an X-ray is mandatory to exclude tibial fractures, and also helps you with assessing for patellar dislocation if there's a small fracture on the medial border of the patella. But 75 to 80% of knee effusions that present are cruciate ligament injuries. So if you're not diagnosing 80% of those as cruciates, you're missing some. And it's easy to do because it's a hard beast to diagnose in terms of the many different causes and presentations that occur. And contrary to sort of the ankle, in some ways the cruciate injury isn't that painful. Often the medial ligament and the patellar dislocations are more painful than a cruciate injury. So I'm going to play this several times. This is probably the Eagles' most famous ACL injury, Glenn Jakovich, in the old days. So what you want to look for is just how simple this injury occurred. There is no contact from the opposing player. He really is just trying to do a sidestep, and the knee, as so often is the case, just buckles and gives way, putting weight on his right knee as he went down, and that's how cruciate ligaments often occur. So you don't have to have a massive contact or anything. It's often a non-contact injury. So usually there's an awkward landing, a sidestep, and they feel like their knee went out is the sort of the classic. And sometimes with their hands, they'll show that just a little movement of the knee going out, collapse, pop, and most of the time they go to the ground, they're unable to wait there for a period, and the swelling, well, I've said rapid there. It can be rapid, but it can be overnight as well.
Well, look, we're lucky to have Matt here. Well, not lucky for Matt because he's injured his knee, but when did you notice the swelling?
Probably Saturday night. After the game, yeah.
After the game.
Yeah.
It's a leading question to work out when was the onset of inflammation. In Matt's case, it's happened a few hours after his basketball game where he injured his knee, and straight away he's got a real tense effusion, and you can do a thing called a wipe test where you wipe the medial aspect of the knee joint and then gently push on the outside, and you'll just feel this real gooey, fluidy, porridgey feeling here. So straight away Matt's got an effusion, and we talked about those structures that you'd be suspicious of. Just while I'm here, this is that sort of patellar apprehension test. So thinking about a dislocating kneecap, you just slide in the kneecap laterally and just see if you can elicit any pain there on the medial patellofemoral ligament. So this is your dislocating kneecap test, along with the single leg squat that we did back in the room. For the meniscus, you're looking at joint line. Sorry, Matt, I'll just put a little mark here. And you're palpating along the medial joint line for any discomfort, and likewise on the lateral joint line. Also, just above the joint line on the medial femoral condyle is the origin of your medial collateral ligament. And this site here is the most common point tendinous site that you'll find if someone has injured their medial collateral ligament. So the test we do, I'll just be very gentle with you, Matt. We do just this valgus test, and what I'm feeling for here is everything snapping tight. And so your medial ligament is fine. There's no question there. And you do the reverse direction to stress the lateral collateral ligament. The meniscus, we bend the knee up, and then just with the heel, you're just doing little circular movements and just looking at sort of, almost you're just scooping the knee while it's in a flex position, and then extend it. Any pain there? A little bit? Yeah. And with an acute meniscal injury, you'll find you'll get quite a painful response by the patient. Finally, looking at your anterior cruciate test. Now, the Lockman's test is a good one, quite easy to do with a bit of practice. Now, what I'm going to do here is just lift Matt's tibia up, and while I'm just anchoring the femur. Now, what I'm trying to feel here is the cruciate ligament, the anterior cruciate ligament, to snap tight like a cord. And in Matt's case here, it's not doing that. It's just going well and truly beyond that resisted tension. And so you can see my left hand, how I'm really gliding the tibia up, and it's just not snapping tight. Can you see that? And you can just do this with a little jiggle, and again it's not getting that tightness. With Matt's good leg here, just relax, buddy. Very important to have the patient relaxed. If they've got their hamstrings all tight and spasmy, you won't get this response. But you'll see this one here, I'm just snapping tight, and I can feel that cord-like tension of the cruciate ligament. And so, again, in your clinic, you can drain this, and you're expected to see some blood, but that will also give the patient quite a bit of relief. Obviously, then bandaging up, supporting, icing it, and just going to your shutdown regime that we said before. And you need a few days just to let the knee calm down, and then make a decision on management after that.
So in the management, certainly if they're if they're full weight bearing when they come in, they can stay full weight bearing, and often they are. But if they're non-weight bearing due to injury to other structures, and maintain the non-weight bearing until they're comfortable. Again, the Rice principle applies, and as mentioned, early aspiration. Often you see these patients, they're sweating, they're in constant pain because of the pressure phenomena of their tensive fusion, and they are delighted when you just aspirate the knee, and you can get anything up to 130 mils out of some of the big guys, and they often will come in on crutches. They can't weight bear because of the tenseness of the fusion, and you aspirate the knee and they walk out with the crutches under the arm, and everyone in the waiting room is very impressed. Who needs an operation? Well, if they've got an early locked knee, or they've got a severe posterolateral corner injury, then it's early surgery, or the meniscus is badly damaged. But most of the patients go on to elective surgery. The surgeons like to wait 4 to 6 weeks, get the effusion to settle down, get range of motion back into the knee, and operate at a delayed time period from the initial injury. So there's a bit of a contradiction there, because you'll hear about the high-profile players being operated on straight away, and whereas the general member of the public usually has a 4 to 6 week wait. But the 4 to 6 week wait is a better choice. It's just the pressure that they go in and operate quickly on the high profile people. And then you will deal with patients who have ongoing or have the unstable knee, have knee instability. So they've had their cruciate ligament has not been diagnosed. Often they haven't presented. They don't think it's that bad an injury. And they turn up 4, 6 months, 2 years after injury, telling you that my knee gives way once a month or once every 3 months. I just land awkwardly, it goes out. That is a story of a cruciate ligament injury. And if they've got instability, they need a reconstruction.
Ken, can we move to something completely different? Ever since the Olympics and the rowing team with the young lass that collapsed from muscle fatigue before the finish line, patients intermittently ask about muscle fatigue during their training. Is this something that you see in non-elite athletes, and what exactly happened?
Well, they call that incident, lay down Sally, and she just lay back in the boat. Now, there was some controversy that she may have actually done that a few times before when she gets a bit puffed out and thought, I'm out of it, which you don't do in a team sport. You just keep on rowing till you all die together.
That's it.
But, there's this issue about lactic acid build-up if you're fatigued or you have another intercurrent illness or you've overtrained or all sorts of reasons. And there's, people just do collapse. And like you see in marathon runners who collapse, or the classic, of course, is the Hawaiian triathlon, where people have ran and run, all this miles and miles and miles, and 100 metres from the line, they drop. So the fatigue is a big issue. It shouldn't really occur in the standard recreational athlete at all, unless, of course, they're not fit enough to do the exercise in the first place. But in the top athlete, that can be a sign of just massive lactic acid build-up. Sometimes it's a sign of something else. Ron Clark, when he collapsed in Mexico, he had mitral valve prolapse and he'd had ruptured a cord knee tendon, and therefore he had massive sort of mitral regurgitation. So there are
Not a good time to find out.
Yeah, and then the athletes who, I've had a triathlete this week, she fainted, then had a post-ictal little fit after she fainted, and she had quite significant iron deficiency. But in our general community now, the number one cause for muscle fatigue and tiredness in any recreational athlete is the use of statins. So all the statin people getting their myalgia, they go to lawn bowls, they go to anything, and they ache. It's worse so you have to stop their statin for them. Or go onto a water-based statin sort of thing. So it's not just
water-based statin.
Well, some of the statins, like Lipitor, for example, is more fat soluble.
That's atorvastatin.
Okay,
yeah.
Whereas Pravachol is a more water-based statin. So there's an argument that switching down, it's not as potent as the statin. Of course, people are now saying you should go on to Crestor because, again, that may have less muscle more tiredness or the myalgias or even the CPK elevation. So that's an issue from a pharmacological point of view you have to look at with the veteran athlete nowadays. And then finally the hydration issue is critical, probably because most people take too many salt replacement solutions and they basically almost overhydrate themselves, and then they have too much water, and it's not so much that they underhydrate nowadays, they almost overhydrate. So the collapsing athlete that we see now at fun runs and everything has usually got hyponatremia, and they've diluted their salt out so much with so much fluid. So there's electrolyte issues as well. So.
Is that less of a problem if they're using some of those replacement solutions that are marketed as Powerade and Gatorade and that kind of thing? Would you recommend those for recreations?
They should be banned. I mean, they're a waste of time, like bottled water is a waste of time. They really just should drink ordinary tap water with a bit of cordial to give it some taste, because in the events almost all of us compete in, which is under 90 minutes, there's no evidence that electrolyte replacement has any role at all. You have to be doing something over 2.5 hours, and then you may need some Gatorade. So you should throw them out of the clubs, ban them, in fact, because they cost too much money. Have you ever seen the price of Powerade? It's ridiculous. And it really is just basically...
Just cordial and salt.
Cordial, a little bit of salt. You can make your own. It's a joke, but they're beautifully marketed, and you've got companies who have these pseudo-scientific institutes, like the Gatorade Science Institute, to produce this thing. And, of course, the team that Gatorade was named after, the Gators in America, a football team, they haven't won anything for about 50 years.
Oh, dear.
So it's a bit of a joke. It's a marketing thing. And of course, it doesn't do what it says.
Okay.
Yeah.
So if we have a younger patient who isn't taking a statin,
Yeah.
but who does present with intermittent fatiguing of muscles, say, if they've gone for a long bike ride and then hit a hill at the end
Yeah.
of it, or they're just trying to train up for a half marathon or something, you'd suggest just investigating along those lines that you've mentioned, so listen to their heart and their lungs.
Yep.
And just do a basic full blood count and iron level and urea and electrolytes and creatinine.
And iron deficiency is incredibly common. The problem is that iron deficiency is underdiagnosed. When you train, ferritin is an acute phase reactant, it goes up. So you measure ferritin, you say, oh, it's 80 or 90. But then if they were to rest, you'd find, whoop, it slipped down, it may be 25, 27. Now, normal,
so
say
worth
30.
doing a full iron study profile rather than just a ferritin.
And you do that, and then you think, well, look, should we do it when they've rested a little while? Because, so we, for our Institute of Sport Athletes, will say if your ferritin's less than 50, we will supplement. Now, 50 is above the so-called lower limit of normal. And the lower limit of normal in some labs is 20, some 30. So 50, we get a little bit concerned. And then we'll supplement them.
How long would you supplement them before you would expect an effect to occur?
Oh, we give them 3 months perhaps and then repeat the iron studies at that stage. But often, I don't know why, but many people with iron supplementation feel better within a matter of 10 to 14 days. It's the old story when mums used to have the babies and they'd been iron deficient after baby was born, and the obstetrician would give them some iron at the hospital before they went home. The next week they thought, I feel good. So whether that's the iron, whether it's just going home, but there may be a metabolic reason behind that, yeah.
Ken, we don't hear much about swimmers having injuries, but I suppose they must get them. What sort of injuries do swimmers come to see you with?
Very few. We hardly see any swimmers at all. The most common thing used to be with swimmers having sore shoulders. Then all their coaches said, look, if you don't have a sore shoulder, you're not training hard enough, so you have to live with a sore shoulder. So there were lots of swimmers used to turn up sore shoulders. You examine them, you think, oh, a little bit of impingement. They used to get their corticosteroid injections in the subacromial space. Totally overmanaged. They didn't need that at all. And they just learned to live with sore shoulders. But occasionally they can have, an abnormal shape to the acromion. They can have true impingement problems, so you might need an ultrasound, an X-ray with an outlet view to look at the acromial shape and say, right, you do have a problem there. But usually it's just a normal thing in swimming. You have sore shoulders. But swimmers have other things, like they have goggle rash or allergic reactions to the pool water and lots of other things. They'll get poor hygiene, they'll get the problems with athlete's foot and fungal infections because
they all get thrush, really.
They get thrush, and they'll also get pityriasis versicolor on their skin because the towels and the moist environment where they prepare themselves. So a lot of it's just good general medical problems, and you just work them through those. But injury is very uncommon. The big problem we now want in swimming is not to overstretch, because you'll see them beside the pool that somebody will grab their arms and pull them back and put their knee in their back almost to stretch them. So if you take the flexibility beyond the physiological range, you can actually cause significant hypermobility of the joints. So some of those joints that flop out have probably been overstretched, particularly the shoulder.
For the kind of rank amateur who just decides to hop into the local pool and do 10 or 15 or perhaps 20 laps every day, are there any things that we should watch out for?
Not really. I mean, I think that you just have to encourage it more. The last thing we'd ever want to do is say anything bad about swimming, because the overall benefits of swimming are so enormous that you sort of try to underestimate any particular problem. But I think basic hygiene is the most important thing, and apart from that, they'll be fine. But I suppose the other thing with a lot of people are told by the neurosurgeons or to be after back problems, you must swim. And of course, what the surgeons forget to tell the patient is that, can you swim? And the patient says, oh, yes, I can swim. And then you watch them swim, and their legs hang down. So they're much better swimming with a set of flippers. So they keep the body flat in the water, and therefore there's no strain on the back. Because otherwise, they do 2 or 3 laps, the feet are dragging in the water, and it kills them. So flippers keep horizontal. So the key in swimming is stay horizontal in the water. And if they can do that with the flippers, that's the best way. And then the patient will say, oh, I feel like a dag, I'm going to the pool, I've got my goggles, I snorkel. When they get there, every other person there's got the same. So they just join in. That's fantastic.
Shoulders. Again, history is always important for these. How did it happen? What did you feel? How was your pain initially? What did you do? And what treatment did you get? So the same questions again as for the other injuries. And then what are the current symptoms and what is your previous history of shoulder problems? So really much the same as the approach for the knee. Examination, inspect the shoulder contours, palpate the various structures around the shoulder, look at their range of movement, and the special tests, apprehension for instability, horizontal flexion for AC joint, and neurological examination may be important because some of the shoulder pain is actually coming from the neck. Some traction injuries to the brachial plexus can occur in sporting environments. The probable diagnosis, the most likely thing is probably an AC joint injury, followed by a glenohumeral subluxation injury and clavicular fractures. So the AC injury, usually a fall onto the shoulder, footballer coming down badly, lands heavy on the shoulder, or gets a good hip and shoulder from someone else. There's a grading system, which I'll show you in a second, 1 to 6. Treatment for 1 to 3 is conservative with rest, ice, support the elbow, anti-inflammatories, analgesia and physio. And if there are 4 and above, then they go to the surgeon. So this is the grading system. So 1, 2, 3 are basically increasing severities of disruption of the acromioclavicular ligaments and the ligaments between the coracoid process and the distal clavicle. So even the worst one, where there's quite a severe tear of the coracoclavicular ligaments and there's a step, but usually the clavicle is still somewhere in location to the acromion, can all be treated conservatively. In grade 4, that's where on your superior view of the shoulder, the clavicle's gone posterior. That's one for the surgeons. Type 5, complete disassociation. Type 6 is where, I haven't seen one of these, but the clavicle can sublux inferiorly. So 4, 5, 6 all need the surgical opinion.
I saw a patient very recently in surgery who'd come back from the snow, and having been skiing and fractured his humeral head and neck, everybody had completely missed the glenoid fracture that was lurking behind it. And I was wondering whether there are any particular lurking injuries that you know of that people should watch out for with any, that associate with any sports, and whether you could comment on skiing injuries.
Well, a lot of people in Australia ski, and it's much cheaper to go, for example, now to Japan to ski with a nice soft snow up there than it is almost in Australia. So a lot of ski injuries. Most of our people now, we say get fit before you ski. It's very important, even to the point of hiring a treadmill or hiring a cross trainer at home for a month before you get fit to do it. Skiing injuries, again, are not that common despite the amount of people that ski. We still see cruciates, we still see fractures, and some of them you can't, it's inevitable, some of those traumatic things. The hidden injuries, though, I think the humeral head fracture is quite interesting because nowadays nobody would go for proper surgery or review until they've had a CT scan right through the shoulder. You've got to know the position of the whole shoulder complex. And the reason for that is that sometimes there's subtle degrees of posterior dislocation that are missed. If you don't do a CT scan, you'll miss that. So good quality imaging is important. Kids get a lot of physeal injuries when they ski. So the kid might come back and say, oh, my arm's a bit sore. And then you say, well, come on, straighten your elbow. And the kid's go like, you can't straighten his elbow. So that's very important. The kids will often get these upper radial or humeral injuries when they ski.
That requires surgery, surely, yeah?
It often does, yeah. It needs to be checked because once you've got some flexion in your elbow, if you don't treat it appropriately, that may be left as a flexion deformity. So the kid who might just hold their arm or the leg in a funny posture, because most kids don't complain of pain, they just adopt a posture that avoids the pain and they think that's normal. So you have to be very, very wary about that in kids who go skiing. And particularly the kids who go on the moguls, they do the bops and down, so they can actually present with spinal injuries just because they've been on the little bops going up and down the place. The hidden injury also for adults now is in skiing and also any trauma is neck fractures that are missed. People think, oh, I just hurt my neck. and they come back and you find they've knocked off a spinous process or something like that.
Taking out some transverse processes,
yeah,
I've seen. Yeah.
All of those things. So again, you just got to investigate. Even plain radiology will pick most of that. But it's again just being aware that these little tiny fractures can occur all over the place.
Mm. Are there any particular mechanisms of injury that we should ask about that might kind of give us some clues, or is it just an overall awareness radar?
I think it's overall awareness radar, but the sudden jolt when people sort of come down heavily, or like the kids on the mobile say, oh, something happened to my back's a little bit sore, because that can bring on the symptoms of a child who's got a congenital spondylolisthesis. Suddenly their back's in spasm and they hurt. And you say, oh, you just sprained your back, sonny. But when you investigate them, they've got bilateral defects. So be aware of that. And of
they're always very difficult patients to treat. How do you treat those?
I think you've got to reassure them that it's something that can be managed. Now, there's a physiotherapy program that's been developed in Western Australia by a guy at Curtin University called Dr. Peter O'Sullivan, and he worked with all the cricketers and the footballers who had these injuries and worked on a stabilisation and a program for the back and the tummy. And the results of that are fantastic, or better than surgery almost. So if they go through the good physio spondylolisthesis program, they can almost all go back to full sport, even playing elite cricket again almost. Those that don't, and the gap is unstable, or that bone scan stays hot, or the bone on an MRI is still active, they may need a little screw, but most can be managed with a good physio program. So to be shown that is very important. Mm-hmm. And then it's a maturing thing. As kids mature, sometimes their back gets tighter and tighter and tighter. So working through their posture and their flexibility will help them a lot. But almost all managed conservatively, and they do pretty well.
Sounds good. And since you mentioned cricket, and since the cricket season is winding up, and you've talked about cricket backs, are there any other things that we should be aware of with the cricketers?
Nowadays, the cricketers get a lot more ankle and knee problems, patella tendonitis problems, ankle impingement, jarring of the ankle, Achilles problems, because they put so much more effort now into the pounding of the bowling. Even though their footwear is better than what Dennis Lee and the boys wore, they still have a lot of sort of ankle impingement, ankle synovitis, and patella tendon things. So you have to just watch them as they come. It's like overuse, but at the end of the season, quite a few cricketers end up having little bits of bone nibbled away from their ankle, or some corticosteroid injections for their ankle, post-traumatic synovitis. And toe injuries, particularly sesamoid problems, so they may need to then look at orthotics or a sesamoid bar incorporated into their orthotics to take the pressure off that medial sesamoid over the inner side of the big toe. Mm-hmm. And all these little subtle things that give them the jips. And then I think all cricketers, like every person, should have a full skin check every year, because there's an enormous amount of sun exposure, and the scalp and the hair that's often not examined. Some of them don't wear their hats all the time. So I demand all the cricketers have a yearly skin check. Yeah. And surprising the number of things that are picked up. So that should be a routine. And for their coaches and their managers as well. So you've got to be sun smart. And then occasionally at the end of the season, the guys have copped little finger injuries. They might need them to be checked out. But cricket's not really some people say that cricketers are sports people, but they're not athletes. Now they're becoming a bit healthier, but a lot of cricketers still go down the back of the shed and have all the cigarettes, unfortunately.
You're still thinking of Shane Warne.
Well, they do. I mean, it's amazing the amount of smoking that still goes on amongst that group of people, which you think, why would you do it? But a lot of cricket, without being condescending, is fairly boring, and so a lot of time sitting around waiting for things to happen. So, yeah.
I think one of the problems is that we see lots of sprained ankles. And that creates an air of complacency, because most of the ones we see will usually have a good outcome. The need is to pick those ones which are complicated and how to improve their management. And so beware those who come in non-weight bearing, who have swelling or have an unusual mechanism. The person with the usual mechanism, where they just have an inversion sprain, they just roll and stretch their lateral ligaments, usually the outcomes are going to be pretty good. And I just emphasise with these soft tissue injuries, rice, and there's other therapies that I'll go to in a minute. In terms of assessment, well, certainly inversion, and that's where the complacency comes from, is far more common. But what you need to do is assess the forces involved. Take a history of the mechanism. What happened to you? Were other people involved? Did people fall on you? How long did it take you to get moving again, to get up on your feet? And how much, and a rating of the initial pain and the therapy they received. Because one of the deceptive things is good early management makes a very big difference to how the patient looks when they present to you. A patient who's had excellent early management with a good trainer or a good person at the sports ground is going to have minimal swelling and the ankle looks better. Whereas those who have had poor treatment, continue to walk on it, party on it, drink on it, may turn up some days later with a very ugly looking ankle, but the initial injury is not so bad. So you take that into rating your assessment. And on examination, assess for your swelling, tenderness, laxity, range of movement, and ability to weight bear is often a helpful predictor of severity.
The key with ankle injuries is ultimately in that initial stage is just to secure the ankle in a sense that the patient's not going to do further damage. So the RICA regime of rest, ice, compression, elevation and support still stands. The people who run into trouble, the ones that then with urgency have to get back to work, and you'll often see them in a day or two later where the ankle's up like a basketball and they're really then they've really taken a retrograde step backwards. The ankle becomes swollen, yet the synovitis that seems to bubble and bubble. I think the real key is that early first 48, 72 hours of combining the elevation, the firm bandage and the ice every sort of 2 to 3 hours. You'll shut the ankle down and then you're in a position to then start moving forward by day 3.
Insist on the rest. So some of these people, want to be martyrs, they want to go to work, they want to battle on. That's only going to lead to prolonged disability and maybe complications they don't need. Ice is important, 20 minutes every 1 to 2 hours in the first 3 days. Compression is essential to prevent swelling. Elevation, and I think a lot of people underrate the importance of elevation. Hydrostatic pressure is an interesting phenomenon, how just 30, 40 centimetres of hydrostatic pressure can make all the difference to an injury. So getting the leg elevated as high as possible. Early physiotherapy is good. I still hear patients being told, don't go to the physio until the swelling goes down. You need to go to the physio straight away. At the West Coast Eagles, say this afternoon, someone will roll an ankle. They will get intensive, immediate and early physiotherapy, and they'll have more treatment in the early days than in the later days. The earlier treatment is more important than the latter treatment. Anti-inflammatories are also helpful. There's studies that show that they will minimise the recovery time and prevent long-term disability. And so if you're dealing with a big person, you may give them a double dose. Use 2,000 milligrams in naproxen a day, or double your normal dose of anti-inflammatory for the first 3 days for those bigger athletes. And like a knee, you can also aspirate effusions from the ankle joint to improve comfort and also improve early range of movement. One of the things I see that does go wrong is x-rays where there are little fractures and people get distracted by the fracture in preference to the soft tissue injury. And so if you see this style of fracture here where there's just a small sort of avulsion crack across the bottom of the lateral malleolus, you can ignore that fracture. Maybe these are ones that are severe and they need a cam walk or a back slab for the first 2 to 3 weeks. But what you need to do is concentrate on the soft tissue problems. That is going to heal, no problem. It's the soft tissue problems that need early addressing to prevent complications. When you inspect your x-rays, certainly inspect your bones, looking for fractures, those different types of fractures through the lateral malleolus. But in this case, there's no fracture, it's this widening. So always inspect, after you've done that inspection for fractures, inspect the gutters. And the ankle is a very tight mortise. It should be about a millimetre gap between the articular surfaces. So here we have a 2 millimetre gap, which indicates there's been disruption of the mortise. And even we can't see it, that must mean that the inferior tib-fib ligaments and syndesmosis has been disrupted. And often this is the mechanism, so it's not the inversion sprain, it's an eversion type sprain with dorsiflexion. It tears that inferior tib-fib ligament. You need accurate early assessment And if the joint is widened, it needs open reduction and internal fixation. If not, there'll be chronic problems.
The next phase is obviously just starting to gently weight bear according to pain. And that'll be another issue confronting the GP or physios dealing, is when is the right time to weight bear. And again, in the early stages, I'd always recommend having crutches, and then the patient will naturally start loading the ankle as they feel more comfortable. And then you can start the weaning off process with the crutches. One would hope with a normal ankle by the end of the week. The final thing with rehabilitation, which is often neglected, is regaining the balance in an ankle. And the way I explain it to patients is, with ligaments that basically are chock-a-block with little receptors that send messages back to the brain. When you alter the ligament structure with an injury, you've almost got to hit the reset button and redo the balance system. Many people focus on just removing the inflammation and think they're ready to go back into things. And it's often the balance system that's neglected, and you've still got an ankle that's out of sync with what it should be. And very simply, wobble boards, any little balancing drills they can do on a trampoline or one of those exercise rebounders. They can balance with their eyes open and eyes closed. All that are good little drills that can be done at home with advice. And that's something I'd really stress, to your general practitioners there. Make sure that doing balance work as part of that recovery. Getting the lunge movement is very, very important in restoring function. The normal ankle, and the heel and the foot has to be all on together. The normal ankle, you should be in your teens, 10 plus with this. It's amazing how many ankles remain sore and other problems develop following an ankle injury, because the end result is this movement hasn't been restored. So these are the grumpy ankles that come in. There's not the swelling there, but there's still pain. You might be thinking, is it a talar dome, or is it something that needs to be followed up with imaging? And for a lot of people in remote areas, it's going to be a hassle to send someone all the down. Before you go to that process, double check that there isn't a deficit with this ankle lunge, because purely this could be an easy way out where you can direct the person to make this become a drill. And you can just do repeated lunges, and after the 10th one, hold it for 10 seconds. Do 10 again, hold for 10 seconds. And again, letting them know where the measure is, and that'll become more of a motivational thing where they can then start moving their foot back as they get better and better with this.
Now, you were talking about finger injuries, and you certainly see those in cricket and volleyball and just about anything else really where you're reaching for a ball or liable to be walloped by a pretty heavy ball. In terms of fractures and dislocations in fingers and hands, any hot tips about what needs fixing and what needs just buddy splinting?
Most things, reduced and buddy splinting is all you need to do. But if you've got a loss of length of a metacarpal, for example,
yep,
and so the MCP joint drops back, that needs to be treated. You have to normalise the length. That's pretty important. I think a biggest problem injury is still a mallet finger, and it's so poorly managed.
Yeah.
It's so easy to manage, when the finger's dropping down, just to get a little mallet splint, hold that up there for 3 to 4 weeks.
Mm-hmm.
But the number of people are just left buddying them together, which is not the management. You've got to get it fully extended.
Yeah.
And you can buy them in chemist shops almost, these little mallet splints, or the local OT or hand therapists can get it. But that's the commonest, I feel, mismanaged injury. Yeah.
I think the most commonly available mallet finger splint is still the padded aluminium thing, and the patients don't like to wear them because they're so big and cumbersome. But I've seen just those little thermoplastic ones.
Yep.
And they're now available through physios and OTs, aren't they, in the hospital system?
Exactly, and even a lot of the local physios who look after these sort of teams, netball teams, basketball teams, they'd have them available in their kit. You can buy a box of them if you're a sports trainer, in fact. You just have different sizes, but you're right. But if all else fails, just a pop stick with some tape, that's all you need. So it doesn't have to be elegant, but get it into extension, that's the key.
Yeah.
And
then
after
after 4 weeks, the ligamentous injury will have healed, and do you then have to start mobilising the finger?
No, just let it come out by itself. Yeah, it'll happen by itself. I suppose the thing that concerns us in our practice, we see a lot of people who've had injuries to fingers that have been very poorly managed. And the classic are the lacerations, or that somebody's hyperextended their finger and they say, oh, I will stitch it up. And they miss the flexor tendon injury. It's such a common thing that somebody goes to a casualty department, a young resident, stitches the skin up and forgets, and then the patient comes back later. And of course, by then the flexor tendon's up the arm here, so they have an incision all the way up here to mobilise the tissues. I don't know whether that's just one of those awkward things that happens. But I think to be aware, any hyperextension injury to the hand in sport, doesn't matter whether it's cricket, netball, basketball, whatever, think about a long tendon injury that can be ruptured. It is, again, not common, but it can be missed.
They're fraught, Anything that contains a laceration, I think that does more than 3 o'clocks on a finger or a hand is bound to have copped something major.
And the other things, of course, people having travelled skiing, is the old skier's thumb, where the collateral ligament at the base of the thumb becomes torn. Now, people say, it just feels funny, or it moves a bit funny. That really does need some surgical attention, because once that collateral ligament's been damaged, and you can almost get your thumb to bend sideways 90 degrees, that ain't going to get better by itself. So you get one of the hand surgeons to reconstruct that.
So this would be something where the patient's kind of come down and bent their thumb right out.
Yeah. And so, the pole, they're skiing, and the pole grabs and bang, it pops it back. It's almost like they've dislocated the MCP joint, and you then, it doesn't...
Do they not get a little avulsion fragment or something that would give you a clue on the x-ray?
Sometimes there's a fragment, sometimes it's just a ligament, but it's so easy to examine clinically. I mean, it's so unstable. And the patient holds it like that and says, oh, look, I'm okay. But the reality is that when you mobilise it, so dunk, it just comes out. Yeah. It's not a nice look.
I want to touch on fingers, because really we apply those principles to the ankle sprain, and the problem with the ankle is it's the dependent structure, and if you don't elevate it, don't ice it, you get the problems we talked about, the chronic swelling and induration, and then you see your finger sprains or dislocations. And so often we are able to reduce these. This is a simple dorsal dislocation, and often it's reduced well with a pull, and so appropriate traction. You're sort of pulling. So when you try and reduce it, if they turn at your practice, you're really just trying to apply a longitudinal force and a lift to get the middle phalanx back over the proximal phalanx and reduce it. And these are the simple fractures, simple dislocations. But there are many, many different types, in the same way that the ankle has a multiple of injuries that can occur to that joint. The finger has the same number of variations in injuries. If it's a volar dislocation, it's much worse. It often ruptures the volar plate and becomes unstable. There's collateral ligament damage, articular surface damage, and so the dislocated finger is also a complicated beast. And so we need to be not be complacent in its treatment. But the other thing that happens is, like the athlete who says, oh, it's just a finger, it's not that bad, and they ignore it, we get the same problems, particularly with chronic swelling and pain and stiffness. So we need to treat finger sprains and finger injuries with the same aggression. So they need rest, ice, compression, elevation, anti-inflammatories, accurate assessment. And this may involve putting people in slings, St John of God slings, to keep their hands elevated. That's important. Otherwise, they tend to walk around with the hand down and that hydrostatic pressure increasing the swelling. And you see what we call footballer's fingers, a footballer who's had inadequately treatment with multiple swollen, stiff joints throughout his digits. So the only message from this part is, apply the same principles of that ankle sprain, the complicated beast that it is, to your finger injuries as well. And beware of them, because they do produce chronic disability if they're treated inadequately.
Finally, Ken, our local footy teams are mobilising for the season. They're down in the weights room, they're pumping away, just getting ready. Anything we should watch out for?
Not really, but the biggest problem with weights is people just not having somebody to help them or supervise them. They lift the bar up and there's nobody to observe the posture and the catch position they're in, so they may be incorrect in their technique. And weight training, like if you watch proper weightlifters do training, there are people watching everything they do to get everything right, because you have to do it properly. And then there's the belief that more is better. Well, more is not always better. So sometimes they'll strain themselves and hurt themselves by pumping too much.
Yeah.
Again, the veteran or mature athlete, now we get a little bit concerned that year by year other things happen to their body, and so every year there are youngish guys in their 40s dying of acute heart attacks because their lifestyle hasn't been particularly good, even though they've been playing their footy. Yeah. So, and although you wouldn't say that every patient from the country who's about to play footy at 45 should have a coronary CT angiogram, even in our sport,
start to wonder.
You start to wonder. And look, we have patients who we feel that might be high risk. They've got some odd symptoms, a little bit of tingling in an arm. You think, oh, it's just a crooked neck. And I think you have to be observant. And if you follow what the cardiologists now say, the most predictive test of a problem is your calcium score. So there are a lot of athletes who've had a colleague over the summer months who's died, and they come to you and say, look, Doc, do you think I should have a heart test? And you say, well, what's the best heart test? And again, as a rheumatologist, you say, well, it's not a problem. But as a sports physician, you say, well, look, if you can afford a couple $100, let's get a calcium score and an angio done. Now, you might think that's a bit over the top, but there is probably a role in the future for doing those in ex-athletes who really don't look after themselves. I mean, they go from the good quality food into the Hungry Jacks and the chips very quickly. Yeah. We try to encourage them to continue to play, so the country footballers, we want them to keep playing. We want them to play sport forever. And that's the great thing about the country, they can often do it. So it's good to look after these boys and girls well so they can keep on playing sport, because it's a very important social thing, psychological thing, fitness thing. It's a very
and now
important.
we're seeing them all coming back and coaching their kids and sometimes their grandkids in Auskick, which I think is just tremendous.
Which is great, and if they can stay involved. And just help them stay healthy, that's the thing.
Yeah.
And give them, if they want some help with cardiac screening or anything, just help them all the way through. Yeah.
Ken, thank you very much for your great practical advice tonight.
Thank you.
Well, that's all we have time for this evening. I'd like to thank our guests, Dr. Ken Maguire and John Annear, for taking the time to talk with us. And I'd also like to thank all of the sporting clubs who allowed us to film their training sessions and their fixtures for use in this broadcast. Now, don't forget that if you'd like to review this program or any previous programs, a delayed transmission will be available via internet web streaming next week through the Rural Health West website, and you'll find us at www.ruralhealthwest.com.au. You can watch the programs online or download them as video or audio podcasts and listen to them at your leisure. We'll return again on the 5th of May with a broadcast focusing on medico-legal issues, including a discussion on the legislation requiring mandatory reporting of child abuse. We look forward to your company then. For now, from Jerry Gannon and Dr. Olga Ward, good night and thanks for being with us.